all welcome us all once again, and we're standing on the existing protocol. Thank you, everyone. So today, I'll be reading the citation now for Mrs. Moji Animashaun. Mrs. Moji is an experienced cancer treatment professional with over 30 years experience as a radiation therapist. She retired as a deputy director at the Lagos State University Teaching Hospital in 2018. She has also spent several years teaching and constructing radiation therapy curriculums in both the United States and Nigeria. In 2013, Moji founded St. Cyril Cancer Treatment Foundation, an organization whose mission is to provide quality cancer treatment to Africans, starting in Nigeria. The foundation opened its first clinic in Isolo, Lagos in 2018. In June 2021, a second clinic was opened in Surulere, Lagos. The treatment centers provide chemotherapy and oncology services at affordable cost to many Nigerians. A brachytherapy unit is in process for the Surulere Center. Mrs. Moji has emerged as a thought leader on the subject of cancer treatment in Nigeria. She sits on the board of Radiographers Registration Board of Nigeria, the governing body for radiographers in Nigeria. She is also a trustee of the Association of Radiation Therapists of Nigeria and board member of RANMED, a young professionals a radiotherapy consulting practice based in Nigeria. Mrs. Moji continues to seek opportunities to mentor young professionals and foster best practices for cancer treatment in West Africa through board level involvement. So let's make welcome Mrs. Moji Animashaun. So I would also like to read the citation for the second panelist. The name of the second panelist is Dr. Mrs. Ime Okon. Her name once again is Dr. Mrs. Ime Okon. Dr. Mrs. Ime Okon is a medical doctor with a little over 2 decades of experience practicing medicine in Nigeria. She is a public servant with Lagos State, currently head of Department of Community and Preventive Health, which pioneered free breast and cervical cancer screening services in the unit. Dr. Okon coordinated cancer screening programs of the Lagos State Branch Medical Women's Association of Nigeria for almost 10 years, after which she became the National Outreach Coordinator of M1 in 2017. An astute public health physician with special interest in epidemiology, infectious diseases /NCDs, with postgraduate degrees and diplomas in public health. Dr. Okon is an epidemiologist, graduate of the Field EP Program of Nigeria, NFELTP, affiliated to CDC Atlanta. She played a very active and crucial role in active case finding in the EPID surveillance pillar of the EOC response for COVID-19, especially during the first wave of the pandemic. Passionate about service, she has served and still serving in various capacities in many organizations, medical associations at local, national, and international levels. Nigerian Medical Association (NMA), Nigerian Cancer Society (NCS), Medical Women (N1), Public Health Association (APHPN), Nigerian Infectious Disease Society (NIDS), to mention a few. Dr. Mrs. Ime Okon is the first female secretary of NMA Lagos since inception in 1960. And in this role, she has brought a lot of innovations and effective service delivery to the engine room of the association. She is a dedicated Rotarian, captain of Rotary Spouses, Rotary International District 9110, Lagos and Ogun State, for the imaginative year. She is a devout Catholic, happily married with 3 lovely adolescents. So once again, let's also welcome Dr. Mrs. Ime Okon.
Hello. Yeah, I've been asked to come back to the seat. I wanted to leave the panelists to do the job, but I was asked to coordinate this. I'm sure they are about to ready to give us to give us the meat of the topic. So we'll give each of them some minutes to give a talk, then we'll have a small discussion about this. Who want to start? She must start. Okay.
Okay, so good afternoon, everybody. I want to recognize the people on the elevated table and the people on the table on the other side, which I call the higher table, because the people here are your servants. Thank you very much. I want to stand on the already established protocol. I actually was hoping that we were going to have a lecture first on the enterocutaneous fistula, then we'll now take comments after that. But that being the case, we'll still go ahead and we'll discuss post-operative enterocutaneous fistula. So, going by the word enterocutaneous and fistula, we'll take it one by one. The word entero signifies what is inside the intestine, and cutaneous means skin. Fistula is the abnormal connection between two parts of the body. So when we say enterocutaneous fistula, it means the intestine is abnormally connected to the skin, and this is usually after surgery. It is usually a complication of surgery, and anytime you have a surgery, especially in the abdomen, you can have that kind of complication, and it's quite common, especially in those parts of the world. You wouldn't say it is particularly because of what the surgeon has done or not done, because once you are operating, you have given an incision into the abdomen, you are interrupting the normal what you have in the abdomen. So my abdomen is there normally, and you have come to interrupt. And by the time you now go further into the intestine, and we know we do these surgeries for different reasons. For instance, in the case of colon cancer, if I might use that as an example, there is an abnormal growth in the colon, and you want to remove it so that the person can have a fresh breath of life, if I might say that. We know that in cancer management, as was mentioned earlier, you can manage it through surgery, chemotherapy, radiotherapy. So in the case of surgery, for colon cancer, for instance, you need to remove the tumor, then you now bring the other sides that are okay together. In the process of joining it, there might be a breach, and once you have that, and there's a leakage into the abdomen, there might just be that enterocutaneous fistula, and because of that, you can have sepsis, that is infection, you can have electrolyte imbalance, and the person might even have malnutrition as a result of this. So, in summary, delivering the lecture that I was not So that is just the summary of what you have in enterocutaneous fistula, and if not managed properly, it could be mortal or fatal. It could be very fatal if it's not managed properly. So I would give Auntie Moji, as we like to call her, I will give Auntie Moji a chance to speak. And if along the line there are questions that make us to remember one or more things about post-operative enterocutaneous fistula, we are right here to take them. Thank you very much.
Thank you. Before Auntie Moji talk, as she laid down her, let me just give a hint of what they are trying to say. Now, when there's a problem in the bowel, we cut it and we sew it together. Look at the bowel as two tubes. So when you put the two tubes together, three things can happen. When you put it together, because there are blood vessels within it, it can bleed. Another thing that can happen is that when you put it together, because if you put it together in such a way that the thing is not properly put together, it can occlude, cause what we call obstruction. Of course, the third thing that can happen is that if you put the two together and there's a problem along, there can be an opening. Just like you are putting two pipes together, the pipe can leak. So when that pipe leak, that is what eventually leads to enterocutaneous fistula. So for medical students, I would say LOH, leak, obstruction, hemorrhage, or bleeding. So those are the three complications, and these can occur anywhere in the world, wherever such surgery is performed. This day and age, there are gadgets that helps to prevent that. We have what we call stapler. Look at it from this perspective. Sewing your clothes with your hand and sewing it with machine. Which one? They are the same, I guess. You are shaking your head. Definitely the outcome is not going to be the same. If you sew your the intestine with your hand, the chances of you to have a leak, which can lead to enterocutaneous fistula, or an obstruction or a bleeding is higher if you sew it with a stapler. So when I travel and I saw that in those days stapler is a experimental thing, you will hardly see, except in some critical condition in a developed country, for them to sew it with their hand. They sew it with stapler. Now we have the stapler in Nigeria. If you want to do sew with a hand in Ife, at most it will cost you about 150,000 with addition, everything. But if you want to sew with the stapler, because you need minimum of about 3 stapler, you cut it here with a machine, you cut it another one on the other side, and you use one to put it together. That stapler itself, when we got it about 6 years ago, they were selling it 10,000. But because of exchange rate today, that stapler costs about 60,000. So if you need minimum of 3, that stapler itself costs you about 150. So the surgery that's supposed to cost about 150,000 will eventually cost close to $500,000 because you want to do stapler. And that's the challenge that we have. I won't take over the show. Let me allow Auntie Moji to talk.
Good afternoon, everybody. I stand on existing protocols, and I'm very offended with all my hair and all my time to look young. Just pour my hand and call me Auntie Moji. Anyway, it's a term of endearment, and I think it's actually stuck with me now. But I'm going to deviate from, because I can't compete with the good professor here, and neither can I compete with Dr. Okon. So I'm just going to deviate and look at the psychology of what happens to that patient who has fistula. We tend to treat a lot of the body of cancer patients, but we don't help them as much with their minds, with their what they're going through, with counseling them through the exercise of when they have the surgery. We're talking about a surgery, and I'm sure the I'm not even going to try to enterocutaneous fistula is a very, very painful procedure. So this is somebody who they've already gone through so much psychologically, they've spent a lot of money, and then at the end of the day, they are going through this physical pain, mental torture, not knowing whether it's going to lead to something else. So there has to be some kind of guidance, and I think that's an area that we need to explore in Nigeria with oncology patients, with cancer patients. Oncology counseling. We need to know that it's a special form of counseling, because that patient is the fear of the cancer coming back, the fear of the pain with that leading to something else is a continuous thing that they live with. So there has to be a way for the patient as well as the family to ensure that that patient comes out you give holistic treatment to the patient. So they come out with their body physically well, and they come out with their minds intact as well. A lot of the times, cancer patients are depressed. Their family members are depressed. They don't know what is going to happen to their loved one. They don't know whether they're doing what is best for them. Even when you have all the options, you are not certain that that person, that loved one or that patient is going to get the best care. The doctors, they've just been talking about, the surgeons have been talking about equipment that we're lacking in Nigeria. So even though, you can't afford to send, everybody can't afford to go abroad for treatment. So they don't know whether this that they can afford to give to their loved one is the best. So there's that feeling of guilt, and from the family, there's like I said, depression from the patient, and low self-esteem. Breast cancer, or somebody who has the enterocutaneous fistula, they might have smell issues and all sorts of things that are going to complicate the disease for the patient. So these are things that we need counseling, oncology counseling, specifically for oncology patients, that ensure that they come out tops when they are completed with their treatment. So I believe, and I advocate that when a patient has cancer, from the beginning all the way through, there ought to be some form of counseling from day one through to the end, and follow up, and have that available for the patient to be able to ask questions. A lot of the times they don't understand what the physician is saying. They need somebody to break it down for them in a language that they understand. They feel that, and because we have so few oncologists or oncology surgeons in Nigeria, the physician doesn't have the time to sit down with the patient and explain all the way through. So somebody needs to talk to them, allay their fears, help them through, because if their mental state is not 100%, it affects the physical well-being as well. It affects the ability to get the best out of the treatment. And so we have to continuously, when we think about the physical well-being of the patient, I think it's very important for us to think about the counseling and the mental well-being of that patient as well.
Yeah, I agree with you, man. And one major thing I need to say along that line is that enterocutaneous fistula can be treated very well in Nigeria. There are some few cancers that, with the advent of care in Nigeria, with the advent of, the advance in care in Nigeria, that can be adequately managed. But the problem is decision making. People making the right decision at the right time. Especially for enterocutaneous fistula. If a patient has enterocutaneous fistula, there are some that you don't need to do anything. What you need most is to support the patient psychologically, like she said, and manage what is coming out. And we manage it as if we are managing colostomy, a bag. Just put a bag there, encourage the patient, and don't do anything. There are some that you must operate within a short time. Now, those that you don't need to operate, if you operate them, the result is usually not very good. Those that you need to operate, if you wait and they emaciate a lot, lose a lot of weight, and you now take the decision to operate at the later stage, the result is not usually optimal. So the best thing to do, enterocutaneous fistula occur anywhere bowel is removed and put together. But the most important thing, know the right thing to do at the right time. And for my younger colleague, if you don't know what to do, package the patient, follow the patient to the best hand, and personally hand over the patient to the experienced hand. Don't just take a rush decision. Where we have problem in Nigeria is that when they have issue, there's fear. I used to think that if you do surgery abroad, there will never be complication. 100% everything will be okay. Until I went there and I trained. The first time I trained, I was only allowed to be in the theater. I don't follow the patient to the ward. But subsequently, when we started doing research, I now started getting to the ward. You're not here, any complication. And one thing that changed my mindset was the first time I was in John Okon, one of the leading cancer centers in the world. And I was in the operating theater. And there was if there's a complication within the theater, there's a code they will press. And that code was pressed. And everybody, the implication of that code is that those people that knows what to do about that code must report there. Of course, if you are operating in Nigeria and you have a code, you are the only one that will be dealing with the code. That's a different level of fish. But these days, most surgeons are advised that at least have 2 surgeons in the theater operating concurrently. That's what we advocate these days. At least from West Africa College of Surgery and National Postgraduate Medical. So they pressed the code and everybody rushed in. I was wondering what is happening. Of course, I later spoke with my hosts that what really happened. He said it's an unfortunate case. They were doing robotic hysterectomy, meaning they were removing the uterus of the woman using robots. And they went into a vessel, a major vessel. And the patient was bleeding. So they needed to open the patient up and stop the bleeding. They did, but the patient died on the table. One thing that occurred to me that day is that if this happened in Nigeria, what would my people say? I'm not buying. What waste the life that no? They just waste people's life. They don't know anything. They are useless. But this is happening in the best medical school, probably one of the foremost medical schools in the world. And the patient died. Now, the lesson I want to pass across that I always tell people is that complication can happen anywhere surgery is performed. Let me shock you. Those people that experience the worst complication are even the most experienced. Because they are more aggressive, they want to do more than others. What others will run away from, they want to do it to get killed. But if you are going to go undergo surgery, don't go to those people that know how to do the surgery. Go to those people that know how to do the surgery and manage the complication that can happen from the surgery. And that comes with experience. Now, there are levels of experience when people talk about surgery. Some people, the experience is just they read in books. Some people have seen it, they have managed it, and they have dealt with it. So the best person is to go and also go to people that can call for help. When they have issues, they have people around them. Unfortunately, many people run from teaching hospital. It's unfortunate because teaching hospital sometimes are not very friendly. But for God's sake, that's the place you have the best brain in Nigeria today. In each teaching hospital, you may have 6 general surgeons. In most private hospitals, hardly will they have more than 1 or 2 at a time. Those leading ones have just about 2. But in teaching hospital, they have 6. Imagine 6 people thinking about your condition compared with 1 or 2 people dealing with the cases. Unfortunately, it may not be a friendly environment. But if you can get yourself and attach yourself very well to their head, not registrar or senior registrar managing you, they are doing it, they can manage any complication. The story is, the long and short is that complication can happen anywhere. But in this part of the world, when complication happen, most patients go for it. In over there, most patients, people go home with the complication. But in Nigeria now, by God's grace, we now have people that have chosen to stay back and not go. So if you can get the best hand managing that kind of condition, you can be sure, even if issue happen, you will get better. Breast cancer can be adequately managed very well in Nigeria without any, from surgery, chemotherapy, radiotherapy. We have whatever anybody will get anywhere in the world, you can get it in Nigeria and at a cheaper price. A friend of mine has an uncle that his daughter developed breast cancer, and the father sent the daughter out of the country because he doesn't want anybody to mess up with the child. And the deposit for breast cancer in UK was £200,000. The old man bankrupted himself and paid the money, and so that he can get the best of cure. Unfortunately, the child still died of breast cancer. The wife developed breast cancer, was managed in Nigeria. Today, that wife is still alive. So it's not where you get the treatment that matters, but the quality of treatment that you receive. So as much as possible, when we are encouraging people, get the quality treatment wherever that you can afford it, and I can be sure you'll be fine. I think, is there any other quick questions that we can round it up?
I just have a quick question for you. Yes, from the number of, if you say you have 10 patients who have colonic surgery, what percentage of them would end up with the enterocutaneous fistula?
For me, I think I've been lucky. I don't think I've experienced that in my practice. And the reason, when I was training, I saw that. But in my practice, I've not seen one, because I insist. It may be slightly expensive, although not as expensive as Lagos, what they collect in Lagos. Because I've learned that if my patients will not have mind to go to London to go and get care, and when they get to London, they will use stapler for them for the surgery. And I can get the stapler to use here. I would rather want to use the stapler. So most of the time we use stapler for our bowel anastomosis, either rectal surgery or that. So the incidence of enterocutaneous fistula, even among my younger colleagues, is almost probably 1 in 1,000.
So, Auntie Moji has left, so let me ask my question too. I want to use this opportunity to sincerely thank my teacher for elaborating on the topic. Now, you know there's a way a professor explains something to you and takes it to the roots. So please, can you explain in layman's time, this enterocutaneous fistula, how can a layman know that, oh my God, it looks like what Professor Natishi described, that symptoms, signs, what are those things?
Thank you for that. I don't expect to be on the hot seat, but now. Okay. Now, like I always talk to my medical student and resident, when you put a patient together, you cut their intestine, be it small intestine or large intestine, and you do anastomosis. The second day and the third day, this patient should be up and about. Now, if this patient is not up and about, but let me clarify, there are 2 reasons why we do that type of surgery. Some people they are not very, very sick. We call them elective. They just have symptoms and they call, oh, we discover there's a problem, we need to cut your bowel and put it back together. There are some that the intestine is already blocked before coming, and you need to cut that bowel and put it together. The way both behave at the end of the day differs. You know, those that come with obstructed bowel, they are already very sick before coming to the hospital. Anywhere in the world, those ones, the chances of them having a leak after that type of surgery is higher than when somebody has not been sick and they detect, oh, there's a problem here, we need to cut you. And the lesson is that, please, when you have symptoms, stop treating yourself. Stop saying, it's my disease. And when I have this, I think that it looks like you. Many of us, because we have so many pharmacy shops around, even not manned by professionals. You just have these symptoms. And what did you use? Go and take flagyl. And you take flagyl, you feel better. Because some inflammation around that area resolve because of the antibiotics. And then you feel slightly better. But at the end of the day, the problem is going to resurface. So when you have complaint, please look for the best of hand and get care. So those that have the complication, they don't perform very well. But there are ways by which you can manage them so that you can ensure that they get better at the end of the day. Those that come elective, if you do that surgery, the second day, the old tummy is still disturbing you, you are not getting better, you are getting weaker, your heart is beating very fast. That's what we call palpitation, which is tachycardia. In fact, I always tell my residents that when you don't bowel recession and anastomosis, the first thing you want to be interested in, the first day you get to the patient bedside, it's not even what the patient say, but the pulse rate. If the pulse rate is high, the patient is saying, my heart is just beating boo, 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 boo. It shows that there is a tiny leak. And sometimes when there is a tiny leak, the body manages some. Some the body is not able to manage. Those one the body is able to manage, it will be getting better by the day. But the one the body is not able to manage, the pain will continue after surgery. You complain of pain, they will give analgesic, but the pain will still persist. The heart will be beating continuously. The abdomen will be getting bigger. At the end of the day, you may start seeing something leaking from either the operation site or from the drain site and anything. So if that happens, there is fire on the mountain. That fire can easily be quenched if the right decision is taken at the right time. I hope I'm able to answer that.
So palpitations, pain, if it doesn't go away, just like they advertise, if after 3 days the symptoms don't, what are you supposed to do? Consult your doctor.